Welcome to the Executive Innovation Show podcast, where we bring you real executive conversations with industry game changers and thought leaders. We ask the questions you're thinking, what you're scared to ask, and we make your brain hurt afterward. With your host, Carrie Chitsey, co-founder and CEO of One Touch Video Chat, live video interviews, and the nonprofit Humans Helping Humans.
Hello, everybody, and thank you for joining today's show. We're going to have a great show today. We're going to be talking about population health and social determinants, brought to you by One Touch Telehealth. I have three amazing guests with us today. First, we have Dr. Murali Naidu, who's the Chief Physician Executive at Digital Health Management Service Organization. He's held several physician leadership positions at large health systems and IPAs. He's focused on delivering better health outcomes while increasing efficiency with technology to effectively deploy clinical resources. We also have Scott Collins, who's the chairman and CEO of Linkage. His role there, Scott provides strategic oversight of the company's group purchasing, market research, and the private equity investments in healthcare and the aging space. And we have Ryan Peterson, who's the Senior Vice President of Strategy and Growth for Reveleer, who's a healthcare technology company servicing health plans, medical groups, and provider organizations, and he leads the go-to-market strategy. Gentlemen, thanks for joining.
Thank you.
Great to be here. Thanks, Carrie.
Well, awesome. We have some fun topics to talk about today, all things population health and social determinants. And I want to talk first, just a little bit of kind of background is there's a lot of buzzwords about social determinants and how to affect population health, both from the patient outcomes side as well as the payers to reduce costs, really using better data and technology to really kind of predict who's high risk, chronic care, things like that, and really, non-compliant, and really break that down. So I want to start with you, Dr. Naidu. From the health system perspective, really kind of figuring out who's in those buckets, why it's critical to understand this. Why is this so critical in this kind of day and age that we have where, costs are going up, outcomes are really determinant a lot on, social determinants and environment and things like that. So from the health system standpoint, why is this so critical in kind of figuring this out and really affecting those outcomes?
Yeah, as from the health system perspective, when we think about how we care for communities, when we think about how we take financial risk on, for a long time we use the clinical data to really help us determine who's going to be at risk for various diseases. And what we found is that that's an important first step. But really, when you think about what we take care of, where people have the most morbidity, they have the most suffering, and what drives most of the cost in the healthcare system, it tends to be related to a handful of chronic diseases, which are largely impacted by social determinants. So it's really important for us to understand when we're constructing risk profiles, things like access to care, ability to get healthy, nutritious food, ability to travel to appointments and so forth. All of those things that can really impact the curve of somebody either developing or getting worse on the spectrum of chronic diseases like diabetes. And so that's important. And then also social determinants play a huge role in how people engage back with the health system when we ask them to do something different from a lifestyle standpoint to impact their disease course. So very important for us.
Yeah, and I think one of the things too is that, we talk a lot on the show about the aging senior population, and, what we're seeing now with social determinants, I think is even just kind of the cusp of, we've identified a lot in the Medicaid population and, some in the Medicare population, of course, but as we have more seniors wanting to age at home, as we have shortage in long-term care. Scott, I want to talk, you guys, your arm of the market research side of your company, you guys did a 2019 technology survey for adults 55 to 100, and the over 50 population accounts for 115 million in the US and projected to be 132 million by 2030. When you guys look at that data, one of the things I thought was really great, and I know we've talked about this, is, talking about somebody that's 55 versus 65 versus 85, we kind of class everybody as kind of baby boomers or senior population together. And I know you feel really strongly of like 5-year buckets, right? Because somebody's social determinant at 55 is very different than issues you have living at home at 85 and caregivers and all that stuff. Tell me a little bit about, how the classes and what you guys have learned kind of from that report of how we should be thinking about social determinants in the senior buckets of that large range that you guys have study on.
Sure. Well, great question. We've been doing this study since 2011, and it's been interesting to see how older adults are engaging with technology over the last 8 or 9 years. Historically, though, the boomers have been lumped into this gigantic cohort, and everybody thinks they're the same, seniors are the same. And when we start thinking about it in terms of the social determinants of health, that just doesn't work. Especially with the boomers, when you look within that large population, there's so many different factors that you have to take into account. There's massive discrepancies in terms of their overall health and well-being, along with really significant differences just in their financial health. 2/3 of this population, and I'm speaking specifically about the boomer cohort right now, has very limited assets and minimal resources to support healthy aging. And so it's going to create a massive burden on our system. So we try to think, especially with regard to the social determinants of health, as instead of looking at it from an age standpoint, more life stage. And specifically within that, trying to break them down even further into those categories, like, where are they with respect to their physical well-being, emotional, how do finances impact their ability to provide care for themselves or successfully age wherever they want to. And certainly the data is telling us that more and more, not only do they want to age in their home, they're not going to have the financial resources available to them to live in some sort of retirement setting. So I think the big heading here is one size definitely does not fit all. And it takes some real digging to begin understanding how to tailor solutions to different cohorts within the boomer population.
Yeah, and I think that's critical too. The financial is, it's so expensive, right? Nobody's sitting on $5,000 to $8,000 a month for their parents, or, they didn't, have a long-term care policy that they've been paying on since they were 20, right? That wasn't a thing. And I think one of the things we've talked a lot about recently is just culturally, right? In a lot of cultures, you bring your parents in, you take care of them, and now you have 2 incomes, working household, nobody's sitting at home. And it's not like it was when our parents brought in their parents and so forth. And I think one of the things I think we don't talk enough about, that I think if we're having this conversation in 5 years from a social determinant standpoint, is really caregiver, right? Oh. There's a lot of people that are 85 that don't have any family. There Absolutely. Is no caregiver, right? And their health is significantly different than somebody that has a daughter or a son or whatever that can come over and bring meals and that can take them to doctor's appointments and have them not miss doctor's appointments. And so I think a lot of times we don't talk as much about that caregiver relationship from that standpoint. So Ryan, I want to talk, kind of take that over to you for a second, as you guys are all about kind of insight-based healthcare and really looking at managing those risks. Like, what are you seeing as some of, the risk from your guys' standpoint on social determinants that are kind of outliers?
Yeah, I think it's an exciting time in our space because there's a lot of buzz around social determinants of health. There's a lot of folks who, vendors in our space who have a lot of data at their disposal through their clients, like whether it's anonymized or, specifically for the client. But I think there's a couple pieces that are keeping the big leap forward for that standardization. One would be a lot of the data isolation. A lot of this stuff is on Excel spreadsheets. It's locally with a food pantry or, in various social services, in addition to EMRs and, of course, the headaches that it always brings of interoperability of EMRs, and then just plain medical records. So, I mean, despite the information possibly being there in those hills, the gold in those hills, to really be able to then aggregate this data, normalize this data, and then have some action insights, there's just such a long way to go in terms of actually being able to distill and make that meaningful information. So we're working on it. There's a lot of other folks working on it, but that's kind of the slow, steady pace.
Yeah. And that's kind of where I really want to head to here, is really kind of moving that needle, because there's a lot of companies that have great data. There's a lot of MCOs and health systems that are starting to gather all this data, but I think the needle really hasn't been moved. And I think we're going to see down the road, what do you really do with this data? Now, I think there's, great health systems that are starting to move the needle, but it really comes down to, now we have this data. Now we can predict, the top 5% or 10% or 20%, but what do we do? And now there's a lot of technology. And I think, Scott, to your point earlier, I think we've kind of shadowed baby boomers as they don't like technology, but give them a smartphone, a slot machine game, FaceTime with the grandchildren, they're good, right? Yeah. And so I think we can't really class everybody as not being technology. So Dr. Naidu, I want to go to you first. What are two things that you think that are really moving the needle or can move the needle when it comes to population health and social determinants in regards to patient outcomes from your perspective?
This is a really great question. When I think about our ability to predict risk, that's really part of the solution. To your point, the two things that really I think will move the needle is then for us to be able to identify what things are going to impact the specific individual sitting in front of us who we've now identified as high risk.
Yep.
So for example, if we're trying to reduce the risk that somebody who's just discharged from the hospital after an exacerbation of congestive heart failure is going to be readmitted or come back to the ER, there are a handful of things that ordinarily our care coordinators would do. What are the 2 or 3 things that are most likely for that person to reduce the chance of being admitted or readmitted? That's really going to be important. So that prescriptive component to analytics on that foundation of data that includes social determinants and clinical data is going to be huge. And then the other thing is, what are the right things to help that individual engage with us as a health system? You mentioned this idea that, we previously believed baby boomers didn't want to be involved in technology. My mother has the Facebook app, and to me that was shocking. It was a big thing. They certainly want to engage. So the question really is, what is the right way to reach out to somebody? That individual that I was mentioning for a readmission avoidance, do they prefer to have an appointment made for them and then get a reminder text or a phone call, right? That kind of information is really going to help make outcomes improvement really at a much more precise and therefore efficient process.
Scott, what are your 2 things on patient outcome side?
Yeah, and I think both of you folks have really hit on the key issues. Drilling a little bit further into utilizing artificial intelligence to not just analyze clinical, financial, and social data to improve health outcomes, but how do you really distill that down to the individual level to address a couple of things that are hugely important, like food insecurity and housing instability? There's companies out there right now, some of which we've invested in, that do this at scale, but can boil that information down to the individual level and start layering those things on top of the plan of care, and are beginning to do this at scale, which I think is really exciting. With respect to how older adults want to engage with technology, like I said earlier, it's not a one-size-fits-all approach. We really need to spend some time incorporating the users into the research. And a lot of times what we've seen, particularly whether it be through our research capability or through our investment activities, is that there's lots of great things being developed in a vacuum, not really taking into account the feedback from the end user or the informal caregiver. So I think it's really important as we begin developing these solutions to not leave them on the roadside, but incorporate them at the front end of innovation, as opposed to asking their opinion after things are developed. And then another area that I think is really interesting that has come about in the last few years are virtual hospitals and the impact they're having on patient outcomes. You know, being able to strategically build out this hospital without beds so that they can deliver the appropriate care at the right level, at the right moment for the population, to allow them to thrive exactly where they want to. We've seen evidence that that does lead to better outcomes. And there's, you know, the Mercies of the world, Ascensions and Dignity Health, they've been really focused on this the last few years, and they're seeing some great outcomes.
Great. And Ryan?
I think it's been wonderful to have these tertiary viewpoints and kind of some different altitudes of where we come at it. And I love kind of the one-to-one that Scott's coming at. And so kind of leapfrogging from that, I go back from my view, right, to data. And when I think of the data, we're looking at all kind of like next level technologies and methodologies, right? Whether it's here at Reveleer or in others in our space. And what I mean by that is, of course, NLP, machine learning, even OCR. But if we're going to try to get through those mountains of data, because I do think that the end user should be there on the one-to-one, but also in order to have a sample size large enough of data, understand of some of the segmentation that he was referring to earlier, is that we need to churn through this data to understand like what we're even looking at before we segregate it and segment it, and then get to some of the one-on-one about the solutioning. And so it's going to take the village here, but certainly utilizing those technologies to allow in the background copious machines to run and read through this information to help us filter it and understand. But one of the other pieces you had asked for too, I think, and maybe it's not something that people want to hear, but probably is a lack of incentives right now, really from the government, right? That, you know, when you look at how HCCs and Medicare fall in line, when you look at how NCQA star ratings for quality improvement for those areas, you know, everyone starts rowing in the same direction and understands what they need to do the things to get those dollars. Now, we can question whether incentives are correct or not, or are they the right measures? Are they the right this and that? But I think without a little bit of a clear prize, so to speak, at the end, without the incentivization, I think that that's also allowing a little bit more of the natural percolation, which I don't know is necessarily a bad thing. But I think those are the two pieces that we're going to see here in the near future that are going to try to jumpstart this a little bit more.
Ryan, I couldn't agree more. And you used one word, background, with respect to how technology can be utilized. And I think that's so smart and underemphasized. You know, in our world, the technology seems to be the solution, as opposed to being an enabler that can operate a lot in the background, some at the point of service, but it will never replace that human interaction. So I think that idea that, you know, a lot of this stuff needs to take place behind the scenes, because people are at varying levels of comfort with respect to privacy issues and how much they want technology to be prominent or how much they want for it to be invisible.
Right.
Okay.
So we've talked about a lot of really great things today, and I want to kind of boil up a few of the key things that we talked about. When we're talking about population health and we're talking about shortage, and one thing we didn't talk about today is just the rural access shortage, right? And so a lot of the population health, does use the ED for primary care because, it's closer to go there, as well as convenience and appointment times and all that kind of stuff. In addition to that, we have a lot of technology, as we've talked about today, that's out there. That's never going to replace that human interaction, but we can use insights to really create outcomes, right? And I think, as I said before, we're kind of scratching the surface of a lot of things. We haven't talked today really about remote patient monitoring, but I know a lot of folks are really getting into that for higher risk patients to be able to do things more immediate, to put the patient kind of anxiety at ease. There's a lot of telehealth now with population health and social determinants, that if there's transportation issues or it's a chronic care, rather than having them go into the ED and be tens of thousands of dollars, handle that in home. And then we have this rise in, hospice and home health and everything, boomers. So I want to hear from everybody. First is, how do we take this data? How do we take, from the health system, the MCO side, and full risk primary care that's now really getting into a lot of this data? How do we take this data that we have for these chronic care patients, high risk patients, whatever? Where do you see remote monitoring? Where do you see telehealth, whether it's meal deliveries, whatever it is? Prescription deliveries is big right now for this population. What are some of the things, and we'll start top left to Dr. Naidu, where do you think in 2 years, 5 years, where are these kind of technologies going to come in to really move the needle with some of this data? Where do you see those big buckets from your perspective if we do the same podcast 5 years from now?
So to try to predict the future a little bit.
Yes, and I'm going to track you all down 5 years from now while we record this.
Excellent. It's recorded, so it'll be easy to do.
Yeah.
I think the opportunities that are now becoming available to us to reach people in their homes, in their daily lives is huge. And, for us, the challenge really is, what do we do with that information? How do we use those touch points most effectively? And this goes back to the previous conversation we were having. What is most effective for a given individual? Is a telehealth appointment the right thing from their disease that we're trying to address or their healthcare issue? Is it the right thing for them as an individual because that's how they want to engage? So I think in a few years' time, we will be able to answer some of those questions, and we'll be able to be more effective in how we deliver those different things. Mail order pharmacy is fantastic. Is it for everybody? I love it, right? But it might not be for everybody. So being able to really engage people most effectively, I think, is where we're going to go with this. And then what we do with the information that we're getting now with wearables and various other remote patient monitoring type things, we don't know the answer to a lot of that. If you take, for example, the amount of information that comes in from the Apple Watch, if you were to hand that to a cardiologist and say, okay, now go help this person, we just don't know what to do with that yet. We'll get there, and I think that is a few years away. So those are really the two areas where I think in a few years we'll see some real movement that will allow us to be much more effective in both utilizing these services and delivering care more efficiently.
Yeah. Ryan?
I agree with him. He did mention that, wearables, whether those are the watches, the smart watches that we're utilizing, or whether those are patient monitoring tools that are remote for folks who are aging to live and live well at home. I certainly think in our 5-year prediction could be there. I think that part of it is, I think of the interoperability, going back to kind of beating this drum. And I go back to meaning where is that data going? and how is it getting into an EMR? How is it getting into that cardiologist or anyone's hands? And how is it flagging or notifying them to say, here's a thing that may or may not be important, right? So capturing the data, again, we're kind of adding to the mountain, but I don't know if we're cutting through it yet. And I think the other piece there is that when you look at individuals who may be low income, who are in rural areas or in kind of these urban areas that where your food desert might be and your lack of libraries and all of this kind of item, it's still about the accessibility to mobile networks or to the internet, so that that data, even on if we're giving away to patients smartwatches and things like that, that the data is coming in. So there's still the connectivity down the way. Don't necessarily have the answers, but if we can help solve some of the connectivity issues and then some of the normalization of the data, I think that there'll be an exponential leap in what we're able to do with your telehealth, your wearables, and the rest of it of folks being able to stay at home.
Great. Scott?
I think Dr. Naidu and Ryan have both done an excellent job of framing out some of the macro issues that will need to be addressed over the next few years in order to make taking these various technology solutions to our broader population at scale. A couple of things that we've seen over the years in terms of barriers that still are in need of being overcome. Access is one. As part of our most recent study, we took a look at the general population and those that would qualify for affordable housing or government subsidized housing. And what we found was, in terms of access to Wi-Fi, 90% in the general population, right around 33% for that segment of our aging society that I think represents the majority as opposed to the minority. So certainly having the infrastructure necessary to be able to manage all this technology is still a huge area of opportunity and concern. Certainly awareness among our aging population about what solutions are out there that can help improve their health and well-being and allow them to thrive. And then affordability, we're starting to see obviously some really nice progress over the last year or two with regard to payment reform as it relates to virtual care or telemedicine, and that has to continue. But then drilling into a couple areas that I think are really interesting over the next 5 years. One is with regard to transportation. There's companies out there, one in particular, Kaizen Health, who's utilizing a technology platform to streamline the process of scheduling transportation and utilizing a diversified, vetted fleet of transportation resources. So again, not that one size fits all that can lead to better patient or member engagement. And then from a behavioral health standpoint, there's companies out there specializing in that. And what we've seen is just the huge cost associated with our population not having access to behavioral health services. It results in 6 times as many ER visits, 2 to 4 times as many medical claims, resulting in roughly an extra $9,000 a year in added medical costs. So being able to deliver those much needed resources from a behavioral health component at scale, so that instead of trying to provide Band-Aids to our aging population with respect to their mental health needs, we can get out in front and be more preventive. And then the benefits of that are obviously we can maybe make a dent in polypharmacy, the overprescription of drugs for that population, and reduce other risks associated with that overprescription, like falls and so forth. So there's multiple areas of return on investment in these comprehensive behavioral health resources delivered virtually. So those are some areas where I think over the next 2 to 5 years, you're going to see a lot of emphasis, and hopefully it'll make a significant impact on quality of life for our aging population.
And if I could build, if I could build on one point there, as we think about also, Scott, the amount of data that you mentioned that we have access to and will continue to grow, I think we're also going to recognize that there are a lot of biases in that data.
Yes.
Being able to effectively predict, as you mentioned, in the behavioral health space, but also more broadly. There's that Science article that came out about a week ago identifying that a lot of our data in healthcare in terms of predicting risk is biased because we use a lot of claims data, which means you have to come and touch the system somewhere.
That's where I was. Yeah.
Huge gap in behavioral health to the point that you made.
Yeah, and that's what my point was going to be, is that as we look at social determinants, we haven't even seen the cusp of the mental health and even addiction on the opioid side in our senior population, because the stigma is so high. You're not going to see that data because they're not going to come in. We have to be able to ask the appropriate questions to determine that there is deferred depression isolation because they're sitting at home every single day, and maybe somebody comes by once every 2 weeks. You have to be able to ask those questions, because they're not going to come out and say, hey, I'm super depressed. Yeah, it's not going to happen. You're going to get the worst of the worst that come in because of some type of event. But we have to, on the social determinant side, be able to find out about home life and ask questions and say, they could be, here's a flag that they could be having depression. They could be having, based on these medications. That is going to be critical because of the stigma. We talk about, with our nonprofit in the behavioral space, we talk about youth mental health all the time. And youth is the first to flag that they do have a mental health issue, or go to friends but not parents. And now we're talking about, an older generation, that it's not okay to talk about mental health, right? And so
in addition to not being okay to talk about it, they might not have the vocabulary, right? It might not be just because I feel this way today, I don't know that that's depression, right?
True.
It's very difficult.
Yeah, very difficult. So I want to ask one last question, and anybody can kind of answer this. Is, Trump passed a couple months ago that 80% of dialysis has to be home dialysis by 2025, which is right around the corner, which is going to flip renal care. And, it's good for, obviously, for kidney failure and some of the outcomes to have the home dialysis, but that just puts an entire new structure on population health and social determinants of, can this population actually, do they have a home that's clean enough to do this? Do they know how to do it? Training, they have family support. I mean, it really starts from a population health and social determinant. While it does have better patient outcomes, lowers healthcare costs, things like that, I see just an entire new kind of determinant population around renal care. Anyone have any thoughts on that? Or I don't know how up to tune you guys are. So if anybody has any thoughts on that, let me know as it relates to population health and social determinants.
Well, Carrie, I think you hit really some very important key points that need to be considered. And then I would add, so certainly, people's ability to have dialysis at home for all the reasons you said need to be considered, need to be addressed. And we lack the adequate infrastructure to do that at scale, right? In some places we can do it, but in most places we can't. And by the way, 20% of the US population lives in a rural community, occupying 97% of our land mass. So how do we do that then for them where they're very distributed geographically? By the way, the current system doesn't solve that problem because, it's not like they can get to a hospital or a dialysis center very easily.
Right.
And the other thing I think we really need to think about here is we have a health system that's incentivized in a different way, right? So our health systems, for us, this is going to be a real change in the way we do business. And so it's the incentives have to be strong enough to make it worthwhile when we've made these tremendous capital expenditures to build these huge hospitals and so forth, right? Our ability to just move on a dime is limited.
Yeah. So the last question that we always ask on the show is, what is one thing that's keeping you up at night, healthcare related, no wives, husbands, kids, all the issues that keep us up at night outside of healthcare? So Scott, we'll start with you.
Sure. Carrie, you've touched on it earlier, and that is this impending massive shortage of both professional and informal caregivers. Here in the U.S., the value of unreimbursed care is roughly $500 billion annually. And simply put, due to the birth rates in our country, there are fewer and fewer of these care providers that are going to be available to serve the needs of this rapidly aging population. So to me, it's not only who is going to step into that gap, but given what we just talked about in terms of the rural nature of so much of healthcare delivery, how are we going to be able to do that efficiently? Certainly, I believe technology can play a vital role in supplementing those efforts, but the big challenge there is how do we incorporate it and pay for it at scale? So when I think about where are the big challenges in the future, it's how to care for a large aging population with fewer caregivers on a distributed basis, and the need for payment reform that's going to allow us to do that effectively.
Yeah, no, totally agree. Ryan?
I'd have to piggyback on a lot of what Scott said. We I think of Nightmare on Elm Street, where we're all in the same dream or nightmare, right?
Yeah.
I mean, it's totally true, right? Like I was thinking payment reform, but payment reform really is how am I going to pay for the scale that he's talking about? You know, I look further at some articles in the past week of we're not living as long and we're not living as well here in the United States, and yet healthcare costs more than ever, right? And I've recently been speaking with people about even and younger folks, right? But simple non-emergencies and the exorbitant costs that kind of get kicked through healthcare and health insurance, only to come back in those premiums, et cetera. So I think payment reform is a huge piece. I can't say that I know what the answer is exactly. There's some compelling thoughts out there from the Democrats, you know, and how they're going to do it in terms of how you pay for it. I'm not an economist, but yeah, I share the same piece as it relates to payment reform being the biggest nightmare in healthcare that keeps me up.
Yep. Dr. Naidu?
Yeah, I'll go back to the I was making about health systems and generally the health system not being very nimble. So as you know, what's keeping me up at night is how do we get people to be innovative, not just in the smaller organization space, but really at scale across the large organizations, because at the end of the day, we're still going to need some hospitals, not as many, and so forth. And the reality is that it is not easy when you have all of this capital tied up in that infrastructure I was talking about. And by the way, we're a very risk-averse culture because, you know, in my clinical world, taking risk and making a mistake is not acceptable as a surgeon.
Right.
And we sort of translate that all the way to the level of business decisions. And so I think in order to, what keeps me up at night is, you know, how do we become more nimble? How do we try new things as the world is changing very rapidly so that we can close this gap between the level of care we provide today and the level of care we are capable of providing?
Yeah, and I usually don't do what's keeping me up at night. I only do it for the guests. But one thing we haven't talked about today that I'm going to use as my what's keeping me up at night is, you know, having a company in the HR space and having a company in the healthcare space. I kind of hear it from both sides, but it's kind of the change in the healthcare workforce, right? I talking to 10 plus doctors a day. It's all about physician experience and this kind of work-life balance of, hey, I'm charting till midnight. I am going facility to facility. I have these clinical rotations. I've got people in my office and, you know, we've got all these shortage areas. And so as we're talking about this and we're incorporating things like remote patient monitoring and telehealth, that's maybe easing a little bit, some of that. Then you take it down to like the nursing staff, you know, Dr. Naidu, you mentioned earlier is like the case managers, like, there's a lot of retraining that's going to go of, okay, this person's getting discharged from the hospital. You now need to ask these questions to determine based on this data, like, does there need to be a different care plan for patient A versus B because B has caregivers and 75 and other patient 85 and by themselves, you know, doesn't have money to go to the facility. Like, you know, there's all these things that I think we're going to see a big shift in staffing and the role as we have technology, as we're asking people to do more, as we're asking them to expand reach, reduce mental time and spend more time with patients. And how do we do that with a combination of technology and human interaction? So I think as, health systems, as practice groups, as whoever it may be, needs to be thinking about, what does that workforce look like in 5 years with, high competition, shortage, all those things that healthcare is experiencing right now. We really need to be thinking about the medical staff, the nurse experience, the physician experience, that trickles to the patient experience. Because if everybody's burnout, overworked, they're now driving, going to homes, facilities, whatever, it's going to affect our patient outcomes. So that's what's keeping me up at night this week.
Yeah, well, and, so wonderful points. And we have to do all of that while maintaining the fundamental humanity that is the foundation for, by the way, why most of us go into any healthcare related work, but also what's so important when we're caring for each other, right? So the point was made earlier about, technology is really a facilitator in all of this. And it has to be, at the end of the day, a very human thing. So we need to elevate that as we think about these things. And by the way, I'm very optimistic, although this is what's keeping us all up at night, I'm very optimistic about where we're going because, again, we all come from a place, the vast majority of us come from a place where we really want to be here, right? This is something that we really feel passionate about, and there are a lot of smart people doing this work.
Great. Well, gentlemen, thank you so much for being on the show today. If anybody has any questions for our 3 guests today, feel free to submit those and we'll get you the answers. As always, click on the show notes to follow any of our guests today. They're all up to amazing things. Make sure you follow their journeys. Guys, thanks so much for being on the podcast today. Everybody did a great job, and we appreciate all your insightful feedback on the Executive Innovation Show.
Thank you.
Thanks, Carrie.
Thank you.
Thanks, Ryan. Thanks, Scott.
This podcast has come to a close. To hear more from the Executive Innovation Show podcast, subscribe, submit questions, and share the love. Follow us on social. We're everywhere.